Good morning. I and Dr. Hari welcomes you all for the first session of the wonderful GSICON 2024 to this hall. I invite Dr. Santosh Kumar Swain, Associate Professor of Medicine, Sri Jagannath Medical College, Puri, for talking on multi-specialty approach to geriatric care. The time allotted is 15 minutes. 17 minutes, sorry. Please, Dr. Swain, please.
Thank you, chairpersons. At the outset, I thank to the organizers, particularly Dr. Asokon and Anita ma'am, for this opportunity. So, starting my presentation, multi-speciality approach to geriatric care. This specialty doesn't involve doctors. It do involves the paramedics, the pharmacists, the social workers, the geriatric nurses, and even the caregivers. So, how many of us are doing justice in a 10-minute office visit of a geriatric patient? So, the elderly are a source of wisdom, experience, and stability in the world which is constantly changing. So, to care for those who once cared us for is one of the highest honors. So, introducing multi-specialty approach to geriatric care involves a collaborative effort involving various healthcare professionals to address the complex needs of the elderly. This model explores the comprehensive, collaborative, coordinated, and patient-centered healthcare for particularly the elderly. Coming to the statistics, in the world population in 1980, the geriatric population was 5.3% of the total, whereas in 2025 it is projected around 13.3%. In India, the population is 177 projected million, and the irony is that out of that, 40% are below poverty line and illiterate. Why there is multi-speciality geriatric care significance? Because with the increasing in life expectancy, the specialized for care giving adults are more crucial, and due to the multiple chronic condition, the complex health needs to be specially addressed, and for enhancing the quality of life we have to need a coordinated approach. Brushing up the history, in the past the practices of geriatric care was often fragmented, so there was a gap in care and many insufficiency. Now there is paradigm shift in the perspective, and previously the focus on palliative care has shifted to a more holistic and proactive intervention care. The current landscape is to coordinate and have an interdisciplinary team to provide this personalized care, and which will cater the unique needs and preferences of each and individual elderly. With the numbers of elderly increasing in the society, we cannot imagine a healthcare institute which is incomplete and that doesn't have a coordinated specialty care for the senior citizens. Coming to the components of the various multi-specialty geriatric care, the number one is the comprehensive assessment, followed by personalized care plans, chronic disease management, medication management to avoid polypharmacy, psychosocial support, rehab services, if at all required, palliative and end of life care services, coordinate the care, educating and empowerment, and the regular follow ups. In the comprehensive assessment, the team takes a detailed history, physical examination, including the cognitive assessment and the social evaluation, which helps in identify the particular problem. It may be medical, psychological, or social problem. So accordingly, a tailor-made care plan is modified, and the inputs are taken from specialists like geriatrician, other super specialists, geriatric nurses, pharmacists, social workers, physiotherapists, and occupational therapists. The chronic disease management is a challenge in a geriatric patient due to multiple chronic conditions they are catering. Here is a case dignity A 70-year-old man who is a diabetic and hypertensive for the 20 years have developed coronary artery disease, underwent CAG, PCI with dual stents, have nephropathy, neuropathy, unfortunately suffered a fractured neck of femur. Last, he will be planning for corrective surgery. First, he will go to a orthopedician. He will refer him to a cardiologist. The cardiologist will refer to a neurologist and or a nephrologist and so on. The patient will be running from post to pillar to address the corrective surgery. This problem is to be addressed and a multi-specialty team is the need of the hour, so by which the treatments do not overlap, have any conflicts, and the overall health issues can be addressed and toply prioritized. Medication management is the cornerstone of the team approach. The pharmacists play a critical role in minimizing the polypharmacy risk. In addition to the medicine review, there is reconciliation and monitoring that in other way helps to address the adverse drug reaction and optimize the treatment outcomes, which is particularly necessary in the elderly. So there is a principle while prescribing to a geriatric patient. First, consider non-drug therapies. Suppose the patient is having constipation. Rather than giving a prokinetic or a stool softener, we can add on fiber to the diet or address the dietary need in which we can tackle the constipation. Then match the drugs to specific diagnosis. Try to give medications that will treat more than one conditions. Reduce the medicines whenever possible. Avoid using a drug to treat side effects. For a prokinetic action, we give metoclopramide. We have EPS, then we give another drug. That should not be the norm. And review the medicines regularly, at least 2 to 3 months. Avoid drugs with similar actions or same class, and clearly communicate to the patients, including the caregivers. And above all, consider the cost of medications. The patient may be benefited by the medicine, but it will only be limited to the prescription. It will be not taken into real life. So, the necessity of maintaining a personal health record is necessary, in which the patient identifying information, the doctor contact, the caregiver contact, the past medical history, the history of allergics, list of all medications, including the dose, and we have to specify why they are given. Usually a prescription doesn't contain why the medicine is prescribed, but here a specifically personal record of the elderly or a geriatric patient is bound to give the reason why they are taking it and whether an additional or new medicine is prescribed. So, the personal health record will reduce the polypharmacy, and the ADRs also aid in emergency care. Suppose a patient land up in ER, that record will add and reflect all the history and the medication continuing and provide the patient with a more peace of mind. This is a health record which I pledge to adopt for all the geriatrician, the name of the patient, the doctor and pharmacist, including the number, the medication name, why they are used, or describe the medicine, to take the time with the time, and special notes. This chart should be carried in all the patients to every clinics they attend, so that a coordinated approach can be done while prescribing a new drug or substituting a new drug. Coming to the psychosocial support, there the geriatric social workers and psychologists are there to address the mental health issues, including the caregiver stress, and if at all they have any social isolation. Also, this support provide resources and both to the patients and their families. You see the picture. All the three involved in the picture are having eye contact, and the doctor's care they need in addition to the soothing words and assurance that will go a long way. You mind it. This will go a long way to keep boosting their confidence and faith. Rehab service is part and parcel of the geriatric care. Occupational therapists and physiotherapists maintain and improve the functional independency. They can also address the correction of restricted mobility. Also, they provide guide pertaining to daily activities and most necessarily preventing falls. Geriatric rehabilitation is the program which have diagnostic and therapeutic interventions with a purpose to restore the functional ability or enhance the residual functional capacity in older people who have disabling impairments. The aims of the geriatric rehabilitation is to educate the patient, regain independence in the basic activities of daily living, also facilitates the patient adaptation to the modified environment and aid in secondary prevention, falls or subsequently any mishap. If at all a palliative or end of care, life care is necessary, the best approach is to address before a patient preference and the availability of the caregivers, specialized service which is available in the close proximity, and any institutional resources, and subsequently the reimbursement hidden with this care. This is a structured 7-step procedure while we have to communicate a palliative or end of life care. The acronym holds P spikes. P for prepare for the discussion, set up a suitable environment, begin the discussion, the finding out what the patient or the family understand. This is first of all necessary. Then determine how they will comprehend the new information you are giving, provide any new knowledge if required, and allow buffering time for emotional responses, and subsequently share the plans for the next step in the palliative or the end of life care. If coordination is not done in this multi-speciality care, the plan or the approach will be glow flaw. So effective communication and coordination ensures seamless transitions, collaborative results, and continuity of the care. By this regular communication, we can ensure to prevent fragmented services. Education and empowerment takes the load. Patient and their families need to be provided with the education relating to the aging, the multiple health conditions, also the resources available so that they can participate actively in decision making for the providing the geriatric care. Regular follow-ups are required for further evaluation and adjustment or modification of the treatment plan if at all necessary at any stage of care. So, the comparative analysis of a multispecialty versus unidisciplinary, the multispecialty have a more holistic approach, and the studies have shown this multispecialty team approach for elderly care have reduced the hospitalization, improved the functional status, and achieved a higher patient satisfaction compared to other care models. Taking the advantage of the recent gadgets and technological evolution and innovation, in telemedicine we can allow virtual consultation, remote monitoring, which can enable and extend the multispecialty care even to the remote villages and areas and hilly areas. Wearable devices like smartwatches, activity trackers can help in monitoring the vitals, the activity levels, sleep patterns, medicine adherence, which can promote proactive health. With a far distance of 100 to 200 kilometers, we can know or we can get the information of a single living elderly about the activity, or suppose she has missed the medication, or suppose he have fall down, suppose he has gone unconscious. These activity trackers will alarm the caregiver or the multispecialty team so that they can address the issue in a timely manner. Electronic health records. The integrated health information system will streamline the data sharing, and this data can be shared with the care team members so that it will facilitate the care coordination and subsequent decision making. What are the challenges and limitations of the multispecialty care? Main is the resource in form of funding, staffing, or access to any specialized services. Resistance from healthcare professionals also is a issue from organizational structures, culture norms, impede the adoption of these new specialty, multi-specialty care. Caregiver burden is also a issue. Coming to the conclusion, key takeaways. The multi-specialty geriatric care emphasizes collaboration, comprehensive assessments, personalized intervention to address the diverse need. So this is a holistic care approach. Continuous innovation in form of technological advancement, ethical consideration, reforming the policy has driven the evolution of the geriatric care with improved outcomes and improving the quality of life for the seniors. Community engagement in creating age-friendly environments, promoting the caregiver support, and advocating policies for elderly rights and preventing elderly abuse can enhance the well-being of these aging populations. These are my references. Caring for seniors is perhaps the greatest responsibility we have, and here in this GSICON, we pledge and vow to maintain this responsibility to full heart extent. Thank you.
Thank you very much, Dr. Santosh Kumar Swain. You have spoken in time. That is the best point. Other than your approach, multi-specialty approach to geriatric care, that you have said from A to Z, even the new technology is also to be involved. And more than that, in geriatric patients, we have to care the patient like we are caring a child. And apart from the social support, as well as the medications what we give, we have to be very careful that we have to, as you have pointed out, that number of medicines has to be cut down, and also see that drugs which are used should not have a drug-to-drug interaction, as well as it should not cause any sedative effect, so that already they are fragile, and the sedative drugs itself can cause fall and can cause fractures. So you have made it very clear, and it is approach we all have to follow for betterment of this geriatric group of patients. And we can take definitely 3-4 questions from the delegates.
Thank you very much for that very comprehensive lecture. I didn't quite see in your slides the model, the mention of the patient being the driver of the care pathway, unless I missed it. The patient's voice, I think, is the most important. It's good to de-prescribe. It's good to offer the patient services. And I mean patients and not carers, because I remember personal situations in my own family where my father didn't want to have any further anti-cholesterol therapy or, various things which have long-term objectives. It's indicated for the condition he's had, but he knew he was going to die in 4 months' time. And so he said, what's the point of having atorvastatin or this, that, and this? We'll just maintain to the minimum standard. And likewise, a patient having coronary disease who has got a longevity of 2 years and having some other comorbidities. So the question is, how much do we emphasize the role of the patient in driving what care he or she wants to choose? Contrast to pediatrics, where the person doesn't have the knowledge or the insight. Our senior citizens are fully aware of what's good for them. So what is, I just thought I'd ask you this question.
So patient education, they may be counseled.
Choice for the care. That's what I was saying. They're educated people. They know what's good for them.
So
giving them the choices and not forcing the choice.
Suppose for a diabetic hypertensive patient, the lipid profile is normal. He will not be agreeing for the hypolipidemic drug. So anyhow, we have to explain him or her that if you continue, so the lipid profile is irrespective of the presenting your symptoms for acute coronary syndrome or coronary artery disease. So that way you can explain. You can give examples for your previous patients you have dealt. Their lipid profile were normal, but they suffered an acute MI. So the education and the counseling will play a better role in those.
Thank you.
One question. It's the age of, as you said, multi-specialty geriatric care. But one of the very important things is that you are in the center, the geriatrician, the physician, the family physician, or the GP. You are in the center. You are the most understanding of the patient's condition, and you have the most contact with his family members. You are in the center, and all the other referrals must be done through you. You are in the center. It's like a hub and spoke.
Sir.
You do all the referrals and you control what happens to this patient. That will be the best thing for the patient. So actually, otherwise they will end up with a dentist or somebody else who will not know the other conditions of the patients. Supposing they go somewhere and they are given NSAIDs, the patient may have underlying CKD. If you give a letter, if you are with the patient and you give a letter that this patient has CKD, or you give a letter to the ophthalmologist that this patient has underlying other problems also besides his diabetic retinopathy. Any letter like that.
So you refer the patient to the specialist and expect
Yes,
that patient should return at least the prescription should return to us.
Yeah, you are in control. That's
Yeah.
what.
And maintenance of the health records. That card
Correct.
should be all the time with the patient.
We should always advise the patient, not
And-
because of anything else, but that wherever you go, make sure you take your health records, make sure you contact before you go ahead with it, unless it's an emergency.
And you need to write the purpose. Suppose we prescribe a dapagliflozin. The patient will tell, so this is anti-diabetic, why have to take it? So you have to explain the heart failure effects, benefits, rather than its diabetic effects. Suppose the patient, in addition to diabetes, have heart failure, you can write the reason, diabetes and heart failure. So
Yeah.
it should be clear in the records.
Correct. You just that you are in control with whichever specialty the patient goes. Thank you.
Thank you.
One thing I would like to stress here, Dr. Santosh Kumar has focused his talk on he has changed the treatment of geriatric patients from palliative care to holistic approach. And that is one of the most important things which he has stressed on his talk today. And one more thing I would like to stress on this occasion is that usually hypertensive patients a lot of patients are there in our practice. And one of the problem they face is usually patients are given a thiazide diuretics. And a thiazide diuretic is a very detrimental for them because one vomiting can put them into hyponatremia. So we have to be cautious about prescribing, especially thiazide diuretics in patients, elderly patients. Any more questions? I think Dr. Santosh Kumar, let us give him a big hand. He has done a wonderful job. Yes. Thank you.
Thank you.
Thank you, sir. Thank you, chairpersons.